3, 2, 1.
A very good morning to all of you. Once again, welcome to the teaching class of Department of Urology, Savai Mansingh Medical College, Jaipur. Today, we have a class on pathophysiology of urinary tract obstruction. This will be presented by our resident, Dr. Rajesh Kumawat, and will be moderated by our faculty, Dr. Manoj. So I request Dr. Rajesh to kindly share his presentation. Go ahead, please. Yes, go ahead, please. We can't hear you. Yes, go ahead.
The seminar of my topic is Pathophysiology of Urinary Tract Obstruction under moderation of Dr. Manoj Kumar, sir. Urinary obstruction can result in permanent renal damage. The degree of injury depends on severity of obstruction, like partial or complete, like internal, unilateral or bilateral, and it's depend on chronicity of obstruction also, like obstruction acute or chronic, and depends on baseline of condition of the kidney and other factors such as UTI. Prevalence of urinary tract obstruction. Hydronephrosis was found to be more prevalent in women between age 20 and between 20 and 60 years, which was attributed to pregnancy and the development of gynecologic malignancies. And the hydronephrosis is more prevalent in male after age of 60 because of the presence of the prostatic diseases. Now we discuss about the formation of urine in 3 steps. First step is the glomerular filtration. Glomerular filtration is the volume of the fluid filtered from the glomeruli measured through GFR, glomerular filtration rate. Glomerular filtration rate is determined by the net filtration pressure. And the second step is the tubular reabsorption. Tubular reabsorption of the certain substances out of the filtrate from renal tubules by diffusion or active mediated transported. And third step is the tubular secretions. Tubular secretion is the certain substances to be taken up directly from blood into tubules like hydrogen ion and the potassium ions. And net filtration pressure is determined by the GFR. And net filtration pressure is the sum of the glomerular hydrostatic pressures and glomerular colloid osmotic pressure and Bowman capsule pressures. Renal angiotensin aldosterone system. RAS system is a hormonal system that regulates blood pressure and fluid balance in the body. Renin enzyme released by juxtaglomerular cell present in afferent arteriole lead to production of angiotensin II, which constrict the blood vessels and also stimulate the release of aldosterone, which promoting sodium and the water retention and help in the blood pressure and the fluid balance of the body. Renal functional changes with obstruction. There are 3 renal hemodynamic variables, glomerular filtrations and renal blood flow, and the collecting system pressure are changes in obstructive uropathy. All 3 variables are influenced by extent and severity of obstruction. Obstruction is unilateral or bilateral, and obstruction is persisting or still persisting or relieved. Now, unilateral ureteral obstruction. Initially, there is an increase in pressure within the renal tubules of the affected kidney secondary to obstruction and a subsequent decrease in GFR. The vasculature of the kidney attempt to compensate the renal blood flow mediated by the release of vasodilators such as prostaglandin E2 and nitric oxide. There is triphasic changes in renal blood flow and ureteral pressure changes has been noted in unilateral ureteral obstruction. First phase is around 1 to 2 hours. And in first phase, increase in we discussed already. There is increase in pressure within the renal tubules, and then decrease GFR, and then body attempt to increase renal blood flow mediated the release of vasodilator like nitric oxide and the prostaglandin E2. In second phase is lasting up to 2 to 5 hours. In second phase, ureteral pressure remains elevated, but renal blood flow start to decline. And in the final phase, ureteral pressure and the renal blood flow progressively decline, resulting in a gradual loss in renal function. The late phase decline in renal blood flow and ureteral pressure appear to be mediated by an increase in afferent arterial resistance. In addition to impending renal blood flow, increase afferent arterial resistance cause a decrease in effective glomerular capillary pressure and resulting decrease in renal tubular pressure. During the late phase of the obstruction, there is a shift of the renal blood flow into juxtamedullary region to the kidney, and the large proportion of the cortical vascular blood flow is underperfused or then reduced GFR at this stage is therefore not only the result of reduction in the pressure in glomerular capillaries, even reduced GFR is due to low perfusion or under perfusion of many glomeruli in the final phase of the obstruction. Now, bilateral ureteral obstruction or obstruction of a solitary kidney. Atrial natriuretic peptide have a unique role in bilateral ureteral obstruction. Intravascular volume increase in response of bilateral ureteral obstruction serve as a stimulus to secretion of ANP, and ANP is increased afferent arterial dilatation and the efferent arterial vasoconstriction, leading to an increase in glomerular capillary pressure and intratubular pressure also. And increased level of ANP may exert a protective effect of GFR during the bilateral ureteral obstructions. Triphasic changes of renal blood flow and ureteral pressure in bilateral ureteral obstruction or obstruction of a solitary kidney. Initial increase in renal blood flow lasting about 1 to 2 hours, followed by a decrease in bilateral renal blood flow. Unlike unilateral ureteral obstruction, in which the ureteral pressure is initially elevated but quickly decreased to pre-occlusion pressure by 24 hours, ureteral pressure remains elevated for the last 24 hours with bilateral ureteral obstruction. This prolonged elevation in intratubular pressures contribute to the decrease in GFR observed with bilateral ureteral obstruction. Pre-glomerular vasodilation is followed by a prolonged post-glomerular vasoconstriction. This increase in afferent arterial resistance result in increased pressure in glomerular capillaries and intratubular pressure despite to decrease renal blood flow. The positive effect of the increased pressure in glomerular capillaries on GFR is by the persistent elevation in the tubular pressures. Now, partial ureteral obstruction is depending on the severity and the duration of the obstruction. Partial ureteral obstruction behave mostly like unilateral ureteral obstruction. Partial ureteral obstruction result in decreased renal blood flow and the GFR in the ipsilateral kidney. A shift in renal cortical blood flow from the outer cortex to the inner cortex has been documented in partial ureteral obstruction. Now, effect of obstruction on the tubular functions. Main tubular function is urinary concentrating ability. Normal urine concentrating ability is required. Some basic physiologies like a hypertonic medullary interstitial gradient because of the active sodium transport out of the tubule and the countercurrent exchange mechanism. It is also dependent on the variable permeability by the aquaporine water channel predominant by vasopressin regulated. Obstructive nephropathy can disrupt some of all these mechanisms various hypotheses of this pathology, like development of vasopressin resistant or ischemia due to ischemia and decrease in inner medullary plasma flow, also dysregulation of aquaporin water channel. So sodium transport, a decrease in sodium transport in nephron is observed after release of obstruction, and this salt wasting also contribute to the concentrating defect observed in response to obstruction. A significant downregulation in major sodium transporters occurs within the nephron 24 hours after the onset of unilateral ureteral obstruction and occur in both in the obstructed and unobstructed kidney. There is natriuresis following relief of bilateral ureteral obstruction is also, and is typically more than in bilateral ureteral obstruction as compared to unilateral ureteral obstruction. Prostaglandin E2 is also important role in tubular water and the salt transport and renal hemodynamic conditions. So potassium transport in obstructions. Renal potassium handling depends upon the type of obstruction. In unilateral ureteral obstruction, potassium secretion is decreased as proportion to the decrease in GFR, reduced because the reduced delivery of the sodium to the distal nephron and the low volume of flow rate. This lead to minimize the transmembrane gradient for potassium secretions, and there is intrinsic defect of potassium secretion is also present. In bilateral ureteral obstruction, after relief of bilateral ureteral obstruction, potassium secretion increases in parallel with sodium excretion. Proximal reabsorption of the potassium remains unchanged, whereas secretion in the collecting duct is increased. Massive increase in sodium and water delivery to collecting duct acting as a stimuli to more secretion of the potassium, and the high level of ANP also stimulate the potassium secretion in the distal nephrons. Now, hydrogen ion transport, and the hydrogen ion is important for the urinary acidifications, and in obstruction, their obstruction cause a deficit in the urinary acidifications, and the major acidification of urine defect in the distal nephron, and cause of the lack of acidification is the defect in the hydrogen potassium ATPase, defect in the chloride and bicarbonate exchange, and the failure to generate a satisfactory transluminal electric gradient. All these mechanisms are affect to secretion of the hydrogen ion in distal nephron and collecting duct, lead to effect of urinary acidification in the obstruction. Other cation transport, potassium, already we discussed potassium, and phosphate excretion decrease in unilateral ureteral obstruction, whereas increase in bilateral urinary obstructions. Magnesium ion is the increased in unilateral as well as bilateral ureteral obstructions. Now, pathological changes of obstruction. Gross pathological finding is the kidney is enlarged and the cystic appearance, and dilatation of the pelvis and the ureter and the blunting of the papillary tips. Cortex of the kidney is idiomatous and the slightly enlarged. Diffuse thinning of cortical tissue is also. Now, microscopic pathological finding in obstruction of kidneys based on the time of obstruction. At 42 hours of the obstruction, there is lymphatic dilatation and interstitial edema with tubular and the glomerular preservation. At the 7 days of obstruction, the collecting duct and the tubular dilatation, widening of Bowman space, tubular basement membrane thickening, and the cytoplasmic hyalinization. At 12 days, papillary tip necrosis and the regional tubular destructions. At 16 days, there is interstitial fibrosis can be happen, and at 3 weeks, inner cortex is severe tubular loss and the proliferation of the fibroblast and the collagen depositions. And at 5 to 6 weeks is widespread glomerular collapse and the tubular atrophies. This histopath picture is showing glomerulus with segmental sclerosis in central. This image is showing tubule atrophy of the tubules with mononuclear macrophages inflammatory infiltrate. So metabolic changes, many metabolic changes in obstruction provoke a number of changes in the metabolic process. There is shift from oxidative metabolism to anaerobic respirations. result in reduction of the renal ATP's level. The cellular and the molecular changes, progressive and permanent changes in the structure of the kidney, like interstitial inflammation, interstitial fibrosis, and tubular atrophy, and the apoptosis. Chronic ureteral obstruction lead to renal inflammations, increase extracellular matrix formations, tubulointestinal fibrosis, and the apoptosis. This is limiting the potential for the return of the renal function. Transforming growth factor beta-1 is a major regulator of renal fibrosis via stimulation of epithelial to mesenchymal transition, fibroblast proliferation, extracellular matrix synthesis, and the simultaneous inhibition of the collagenase and degradative matrix metalloproteinases. Fibroblasts in the renal interstitium are considered as a primary source of extracellular matrix, and the tubulointerstitial fibrosis is associated with a significant accumulation of the matrix producing fibroblast. Renal tubular cells are most susceptible to apoptotic cell death during renal obstruction in mature kidneys. Now, clinical impact of renal obstruction is hypertension. Hypertension is more common in bilateral ureteral obstruction. The mechanism of hypertension in bilateral ureteral obstruction is a volume mediated, increase intravascular volume. And in unilateral ureteral obstruction, its mechanism is a renin-angiotensin mediated, we already discussed, and more likely to be reversed in bilateral ureteral obstruction after relief of obstruction. Now, compensatory renal growth development of increased volume of the contralateral kidney in response of unilateral ureteral obstruction or renal agenesis. The development of contralateral renal growth is influenced by age and the degree of the duration of obstruction. Kidney enlarge and increase in the number of the nephrons or glomeruli does not occur in the indicating that the increase in renal volume is due to cellular hypertrophy rather than the hyperplasia. Insulin-like growth factor appears to be an important mediator of compensatory renal growth. Renal recovery after obstruction depends on the duration of obstruction. Acute and complete ureteral obstruction is promptly relieved and fully recovery of global GFR can be occurred. And there is longer period of complete ureteral obstruction are associated with decreased return of GFR. Full recovery of renal function occurred after 7 days of unilateral ureteral obstruction, whereas only around 70% recovery of GFR occurred after 14 days of unilateral ureteral obstruction. And after 4 weeks of ureteral obstruction, only around 30% is recovery possible, and there is no recovery occurred after 6 weeks of unilateral ureteral obstructions. Some factors, they have positive influence on the functional recovery, like a smaller degree of obstruction and short duration of obstruction and younger age of patient is the positive outcome of return of GFR, and there is older age of patient and the decreased renal cortical thickness are the factors which are predictor of immense recovery of the renal functions. Clinical presentation of the ureteral obstruction is depending on the site and degree and the chronicity of obstruction. Acute obstruction mostly presented with radiating flank pain associated with nausea and vomiting. And chronic obstruction usually relatively painless and patient may be asymptomatic. In laboratory studies of obstruction is assessment of renal function, measurement of serum electrolyte, urine analysis for estimation of osmolality of the urines, evidence of UTI, and to rule out suspension of medical renal disease with the presence of protein or cellular cast. Assessment of renal function, measurement of the GFR, and divided on the mild, moderate, and severe category. GFR is between 60 and 90 ml, then mild, and between 30 and 60 is the moderate category, and the GFR is 15 to 30 ml per minute, then is categorized into severe. And ultrasonography is the first line imaging in obstructive patient safely by performed in patient with renal insufficiency or contrast allergy Ultrasonographies provide anatomical information at renal size and the cortical thickness and corticomedullary differentiation. Nuclear renography, only imaging modality that can provide non-invasive information about dynamic renal functions. MAG3 is the preferred for diuretic renography. Based on T-half, if the T-half of less than 10 minutes is no obstruction and T-half is the more than 20 minutes is considered is obstruction present. Technetium labeled MAG3, which is actively secreted by the tubules, and technetium labeled DTPA is removed almost exclusively by the glomerular filtrations. Technetium labeled DTPA is the most suited to measurement of the GFR. In CT scan, imaging modality of the choice for patients suspected of having ureteral obstructions. CT scan give information about the obstructing and the non-obstructive stone, and CT urogram also help in diagnosis of the other cause of obstruction. MRI is excellent anatomic information with functional data and avoid ionizing radiation. MR urogram has the advantage of the providing excellent anatomic visualization of the kidney, even non-functioning renal moieties. MRI based on renal transit time defined as the time it takes for the contrast to pass from the renal cortex to the proximal ureters, and renal transit type if the more than 8 minutes, then we considered is the obstruction. Excretory urography is the obstruction suggested by the delay in the contrast uptake or excretions. Identify the level and the potential, the source of obstruction, and some sign of the chronic urinary tract obstruction in excretory urography, like the small renal size, parenchymal thinning, calicial clubbing, and the significant ureteral dilatation and tortuosity of the ureters. A retrograde pylography is the accurately defined ureteral and the upper collecting systems anatomy and can determine the location of the obstructive lesion and increase risk of UTI and sepsis in the setting of the obstruction if the collecting system is not subsequently drained.
Yeah.
Yes. Yeah.
Okay. So again, is the voice clear? So today's topic again is important because we get so many cases of urinary tract obstruction, right? So if we consider urinary tract obstruction, the incidence would be around 1.7 or 2 per 1,000 population. And almost 10% of the urinary tract obstruction will result in acute kidney injury or chronic kidney disease. So it accounts for 10% of all kidney injuries. Urinary tract obstruction, as you all know, that it can start from meatus down up to the calyces. So meatus, stenosis, phimosis, ureteric stricture, urethral valves, bladder neck obstruction, UVJ obstruction, PUJ obstruction, calyceal obstruction. All these can cause obstructive uropathy, and many of them can lead to obstructive nephropathy, right? There's slight difference between males and females in some cases, as you know, prostate enlargement, carcinoma of prostate would be a very common cause for obstruction in males. In females, the commoner cause of obstruction would be like uterine myoma or uterine prolapse. In younger patients, a gravid uterus can also cause hydronephrosis. The patients, the prolapsed uterus can actually pull down the ureters both sides and cause bilateral hydroureteronephrosis and even renal damage. Sometimes pelvic vessels like, because in ureter, there are three important sites of obstruction, right? One is the PUJ, then uretrovesical junction, and the crossing of iliac vessels. In females, there is again another site of obstruction where the pelvic vessels cross. In the broad ligament, the ureter goes just behind the pelvic vessels. That is again a site of obstruction. So, as he said, all these urinary obstruction, can be very important because they need to be treated urgently if they are producing renal failure, infection, sepsis, fever, etc. As we all know, so the commonest cause is the urinary tract obstruction of the bladder outlet obstruction, causing urinary retention. And we all know that we need to put a Foley's catheter to relieve that obstruction. We all discussed about how a chronic urinary retention can produce a post-obstructive diuresis, which in the early phase, in the 24 hours, is physiological, but later it can be pathological and can cause severe dehydration, hypovolemic shock, electrolyte imbalance, and even death. So you need to be very careful in these patients. Catheterization is as old as Hippocrates described it. Previously, we used to have metallic catheters, then rubber catheters. Now we have silicone and latex and all those. And if no passage of catheter is not allowed to pass through the urethra, then you have the suprapubic cystostomy. Again, suprapubic cystostomy is as old as 16th century. The first suprapubic cystostomy was done in 16th century. So we know all this obstructive uropathy can produce various complications. This includes infection, calculi formation, and renal damage. Renal damage, as you said, probably due to the increased hydronephrotic kidneys, which causes pressure on the glomeruli, causes tubulointerstitial disease or fibrosis, ultimately resulting in kidney injury and chronic kidney disease. So obstruction could be due to various reasons, extrinsic or intrinsic. It could be structural, it could be functional obstruction. And the common intraluminal obstruction would be stricture formation, calculi formation, blood clots, papilla, which sloughs out from the kidney, fungal ball, all these. Extrinsic obstruction, we all know, could be due to tumors, retroperitoneal fibrosis, and various other causes. There may be congenital obstruction like pelvic junction obstruction, congenital megaureter, ureterocele, ectopic ureter, posterior valve, all these things. So all this is important because they need urgent treatment, many of these patients, because they can cause various complications. So that was in brief about the pathophysiology that he has discussed it quite elaborately, so I did not go into it. So if anybody of you has any query or anything to add, please let me know. And if any of the faculty member has to say anything, please. Any of
Rajesh?
you? Yes, Neeraj, go ahead, go ahead. Rajesh is here only. Go ahead.
Rajesh talked about you talked about the various investigative modality for the evaluation of upper. You talked about the way. Is my voice clear?
Thoda sa loud. Be a little louder. Yes. Go ahead.
You talked about the various investigations that we use for the evaluation of urinary tract obstruction, and in particular, you talked about the ultrasound. So, ultrasound will only tell you if there is hydronephrosis, loss of corticomedullary differentiation, and all those things. Is there any parameter in ultrasound which can tell you if there is a element of obstruction in case there is no hydronephrosis?
Yes, Rajesh, tell us if the ultrasound study can tell you about the obstruction, whether this tract is obstructed or not.
Ultrasonography is defined obstruction as
Can it say it tells you about the dilatation. Can it say about the obstruction?
No, sir.
Yes, it can say. It can say. So that is about why is he asking the resistive index. You know, probably if you have not heard, resistive index can tell you whether there is an obstruction in the urinary tract or not, right? So it is
So
important.
you utilize the Doppler ultrasonography and
Yes.
evaluate the renal resistive index. And if the renal resistive index normally, I think it's about 0.7, which is considered to be normal. And if it's more than 0.7, then it gives a fair amount of idea that sometimes there is a element of obstruction. And the renal transplant and the nephrologist utilize this resistive index very, very frequently in evaluation of the obstruction, especially intrarenal obstruction, not exactly the hydronephrosis or the urethral dilatation, but the intrarenal obstruction is evaluated by using this resistive index.
Right. Yes, so resistive index is important in the way, right? And for as we discussed last, I think in last probably 1 or 2 classes before about renal artery stenosis also. How does resistive index renal artery Doppler study can help you in diagnosing by resistive index and prognosticating whether this patient will have a better result with stenting or not. So this is again, there are various things in ultrasound which can help you a lot. You said about intravenous urogram. Intravenous urogram, again, with the advent of CT urogram, probably because many of these patients, because of gross dilatation of the they will have very poor functioning kidney, and so you would not see anything on IVU. Sometimes even if the kidney is functioning normally in acute colic, if there is a stone obstructing, because of the artery spasm, you would not find any dye coming into the system. So again, it is futile to do an IVU in acute renal colic and patients who have poorly functioning kidney. So there, sometimes CT urogram, and if not, MR urogram would be a better study if the patient is in CKD, early CKD. Right. Anybody else? Yes, yes, Sudeep, go ahead. Right. So when is MAC3 preferred?
DTPA based on glomerular filtration, and MAC3 is the depend on the secretions of the out of filtration, whereas substances not filtered in through glomeruli, the substances secreted in the renal tubules from blood directly.
So when is it preferred? Is there anybody knows? Yes, go ahead. Okay. So number 1 is yes. Second, in children, you would prefer doing a MAC3 rather than DTPA. Third, if you want to do, because MAC3 will tell you both about the cortical function, like DMSA is usually studied to know the cortical scar and all those when we do in psychometric reflex. MAC3 would tell you both. So when you are interested in knowing about the cortical scarring and everything, then probably you prefer doing MAC3 rather than DTPA. Yes. Anybody else?
So whenever there is a urinary tract obstruction, whether it is a unilateral or a bilateral urinary tract obstruction, there is progressive deterioration in the renal function if it is untreated. Are there any protective mechanisms in the kidney in which the renal function can get preserved or it can get delayed even if the obstruction persists for a longer period of time? Rajesh?
Are there any safety valve mechanism by which the obstruction, the damage caused by obstruction can be delayed or can be reduced?
Sir, in bilateral urethral obstruction is the atrial natriuretic peptide is also positive effect on GFR, especially in bilateral urethral obstruction.
Is there any safety valve mechanism? Anybody? Yes, go ahead. Yes. So conditional rupture causing urinary extravasation, causing urinoma. So that releases the obstruction. What else? Lymphatic, yes, pylovenous, pylolymphatic.
Pylovenous and pyrolymphatic.
Yes. Yes.
Correct.
Yeah. Good. Anybody else? Any other question? Okay. So thank you. Thank you once again. Thanks all the residents. So Dr. Manoj, I will request our moderator, Dr. Manoj, to give his last remarks, and then we will wrap up the session. Yes.
Thank you, Rajesh, for nice presentation. Thank you, sir, for valuable information. Good day.
Okay. Thank you. Thank you. Thanks, everybody. Have a good day.